Hello, everyone. Welcome to today's review session. Just give us a moment to get everything pulled up for you. Hello, everyone, and welcome to today's review session. We're going to be starting in just a moment. We're going to give people a few more minutes to log in, and then we'll get the program started. Thank you so much for joining us today.
Economic loss, damage to her reputation, emotional distress, and physical injury. One local lawyer who works on sexual harassment cases in the workplace says it isn't easy for victims to come forward because of fear of retaliation.
And I also think there's a legitimate fear of how that's going to affect your.
Hello, everyone. How are you? Thank you for joining us today for today's session. My name is Rafael Roman. I am the chair of the Pharmacy Technician Executive Committee for NYCSHP, which is the New York City Society of Health System Pharmacists. And I welcome you today for our review session for the PTCE. First thing we're going to jump into is, excuse me for a second, is some disclosures. So the presenters have been prepared topics based on pharmacy practice experience. Presenters do not have involvement in the development or review of pharmacy technician certification exam questions or content. In terms of how this all came about, it was because of the pharmacy technician law that was enacted on April 25th, 2021. This law creates the registration of pharmacy technicians as permanent professional titles. The definition and title exists under the Department of Education, and bill defines its statute what a registered pharmacy technician can do, including compounding, which will resolve the ambiguity of previous guidance. This will open and allow pharmacy technicians to assist pharmacists in a different way in terms of how to assist pharmacists as directed in compounding, preparing, labeling, or dispensing of drugs used to fill valid prescriptions or medication orders, or in compounding, preparing and labeling in anticipation of a valid prescription or medication order for a patient to be served by the facility, where such tasks require no professional judgment. Registered pharmacy technicians will be able to do the above plus what unlicensed persons can currently do: typing labels, entering our prescription data, getting drugs from stock, and continuing dosage units, etc. Now, for the New York State Pharmacy Technician Registration and Certification, some general requirements: any use of the title Registered Pharmacy Technician within New York State requires licensing. To be licensed and as a registered pharmacy technician in New York State, you must be in good moral character, be at least 18 years of age, have completed high school or its equivalent as determined by the department, and have received certification from a national accredited pharmacy technician certification program acceptable in the department, which is either PTCB or NHA certification. The specific requirements for licensing or licensure are contained in Title 8, Article 137A, or Section 684 of the New York State's Education Law, Part 63 of the Commission Regulations. I know that was a mouthful, but there is a law for everything. Now, who does this affect mainly? This is mostly affecting our compounding pharmacy technicians. But as many of us may know, many of our institutions have created a blanket requirement requiring all pharmacy technicians to be licensed and certified. So definitely check with your management and also with your institution to see what exactly they're doing. But keep in mind, New York State is trying to play catch up with a lot of the laws that have already been enacted from other states. So for instance, other states all across the country have already required either some type of registration or licensing, or being certified and licensed and registered at the same time. As we can see from the displayed map that we see here, there's only a handful of states that do not require or don't have any requirements for pharmacy technicians. New York State is one of the few that have just recently started playing catch up and being part of requiring some registration and certification. So we're definitely coming to be a little bit more on the standard. Now, in terms of pharmacy, the PTCE, or how to register for your exam, you have to prepare for this. So the first step is definitely trying to get familiarized with the type of exams that are out there. Definitely you're going to have to apply in advance before applying for your license and registration. So in terms of taking the sitting for a national certification exam, so whether it be for PTCB or whether it be for NHA, what you're going to have to do is definitely take a look at the requirements that are there in terms of either working hours. So there is some documentation that will have to be filled out, or you would have to go through a review, a certified or a preferred course in order to sit for the exam. So you have to prepare for it, then apply for it, take the exam, and then receive your certification. And keep in mind, when it comes to certification, there are different requirements for PTCB as well for NHA. But generally speaking, in terms of requirements, once you get certified, there are CEs that you will have to complete on a every 2-year basis. So please keep that in mind. Now, in terms of advantages of being a certified pharmacy technician, one of the things that PTCB says is that when it comes to PTCB, certified pharmacy technicians can reach higher to pursue more opportunities for career advancement, prestige in the workplace, and personal satisfaction from delivering the highest quality of care. By earning PTCB's CPhT credential, you can clear the path to achieve other specialized and advanced credentials only offered by PTCB. The advantage of PTCB certifications includes the validated achievement and acknowledgement, improved employment opportunities, potential for higher salary, expand responsibilities, career growth, increased focus on patient safety, and prestige among coworkers. Now, when it comes to the pharmacy, when actually looking at the PTCE, because keep in mind, today's programming is mostly focused on the PTCE itself. There's 4 knowledge domains. There's medications, medication knowledge, which is about 40% of the exam questions, federal requirements, which are 12.5% of the exam questions, patient safety and quality assurance, which is 26.25% of the questions, and lastly, order entry and processing, which is 21.25% of the questions. The test format itself is about 90 questions in total, and 80% will be scored. The time for each exam is about 2 hours and 10 minutes, which is devoted to pre-exam tutorial and post-exam survey. So it's about 1 hour and 50 minutes that you have total for the exam itself. Now, please keep in mind that these are PTCE requirements. There is still an option for NHA, which is the National Health Association, to also be associated to actually get nationally certified. So you can also look at them and their requirements and utilize their exams and look up their study material. Now that we've finished that, and now that I am going to take off captions real quick, we're going to jump into our first speaker for today. So our first speaker for today is Adrian Chatham. He is an EPIC trainer, and he's going to be going over medication part 1, which is over-the-counter drugs and dietary supplements. Adrian, let me get you all set up, sir.
Thank you. Hi, folks. Good morning, good evening, good night.
Seconds. Sorry, ladies and gentlemen, bear with me for just 1 second. Ooh. Oh my God. Hello, Adrian, do you have access?
Yes, do you want me to pull it up on my screen?
I can advance the slides for you if you'd like.
Sure. You want me to just put it up on my screen then?
Sure, you can do that.
Okay, give me 1 second.
Thank you for bearing with me, sir.
All right, let me share my screen 1 second. Okay, so am I cleared to go? All right, without further ado, I'm just gonna go ahead and move on. So hi, my name is Adrian, like Rafael stated. Thanks, Rafael. I'm gonna go ahead and move on with the next slide. Okay, so what are OTC medications and supplements? Okay, they're defined as over-the-counter medications, supplements that are non-prescription medications that consumers can purchase without a prescription or provide a consultation. Just because an OTC or supplement is available without a prescription doesn't mean they do not have drug interactions or are potentially harmful, okay? This is a review for those people that are working in a hospital setting and a community setting. We'll provide important definitions and categories for the vitamin supplements. Hang on 1 second. So I'm going to start with water-soluble vitamins. These are defined as vitamins that dissolve in water and, okay. These are defined as vitamins that dissolve in water in the body. Excess tends to be excreted through waste. Examples of water-soluble vitamins are a few of the B vitamins: thiamine, riboflavin, niacin, pantothenic acid, pyridoxine, biotin, folate, and cyanocobalamin. All right. And then there's also ascorbic acid. It's not a B vitamin, but don't forget that this is water-soluble as well. Okay. There's also fat-soluble vitamins. Unlike water-soluble vitamins, these vitamins dissolve in the bloodstream and are usually consumed in high-fat meats and food items. Examples of fat-soluble vitamins are retinol, which is vitamin A, ergocalciferol, which is vitamin D, tocopherol, which is vitamin E, and phytonadione, which is vitamin K. All right. A next set of medications is allergy medications, right? These are commonly used to treat seasonal allergies, like rhinitis and others, all right? For the antihistamine section, there's diphenhydramine or Benadryl, okay? And this one has a sleep or drowsy effect, so a lot of people tend to not go with this one. For non-drowsy, loratadine, cetirizine, and fexofenadine, okay? As an intranasal vehicle, we have Flonase or fluticasone or Nasonex, right? For eye drops, or for the ocular path, we have olopatadine, hydrochloride ophthalmic solution, which is Pataday, which is now over the counter. It used to be behind the counter. Ketotifen, Zaditor, okay, to name a few. All right, and to continue with the nasal decongestants, this is for cough and cold medications. We have phenylephrine, which is Sudafed PE. We have Sudafed, which is pseudoephedrine. The phenylephrine version was made because obviously there's issues with pseudoephedrine. It requires ID to track the amount of purchasing and can cause harm if it's taken incorrectly. All right. We have expectorants like guaifenesin, robitussin, and mucinex. And we also have cost suppressants, dextromethorphan, calcium, and is also a component a lot of times with robitussin, which is guaifenesin, and mucinex as well. Take note that these can cause a high if you take more than the standard or daily recommended dose. So be careful with these medications. Okay. A few common OTC supplements that aren't necessarily vitamins. Okay. These are supplements that are recommended in conjunction, usually with therapies and non-OTC medications. All right. Omega-3 and omega-369 is used for cholesterol and diet health. Okay. Melatonin can be used as a sleep aid. Azo, which is a cranberry supplement and is usually used for urinary tract health and pain relief associated with period cramps and UTI infections. We have St. John's wort, which is for stress relief and mental health. We also have saw palmetto, which you'll find a lot of men's multivitamins. It's used for prostate health. Okay. To continue, we have milk thistle, which is for liver health. CoQ enzyme 10, which is for gut bacteria health. Florastor, acidophilus. These also promote healthy flora and gut health. Okay. And just as an aside, we're going to talk about formulations. At this point, it is a good time to mention and emphasize that a lot of these over-the-counter supplements, they come in different formulations. Vitamin C commonly comes in a liquid form with a dropper, as well as vitamin E. Omega-3 comes in a liquid form as well. So when considering OTC supplements, take care to look at the different formulations they come in. A lot of people may not want to take certain vitamins and supplements as tablets and capsules because they may be hard to swallow, but would be amenable to a liquid formulation. So take note. Let's continue. I'm going with topicals, okay? A lot of times these are used for atopic dermatitis and allergies, as well as antibiotics and antifungal treatments. Here are a few of the most common ones we see in both retail and the hospital setting. Diphenhydramine cream or Benadryl cream is used for itching and relief associated with allergic reactions like hives and contact dermatitis. Things like hydrocortisone creams and ointments or cortisone are used for allergies, eczema, dermatitis, and itching/redness relief associated with these conditions. Clotrimazole cream or Lotrimin AF is used for antifungal relief for athlete's foot, ringworm, thrush, and fungal nails. Okay, you have triple bionic ointment, antibiotic ointment, which is neomycin, bacitracin, polymyxin B. And this is used for minor cuts, scrapes, and abrasions. It usually helps to prevent bacterial infections. For pain management, we have a class of medication, and this class of medication is used to treat a wide range of aches and pains, as well as used in conjunction with other pain regimens. A lot of times these are prescribed along with much stronger, behind-the-counter pain medications for breakthrough pain. And these can help with recovery and functioning for everyday activities, when you're dealing with injuries. So the first one, and it's probably the most popular, is acetaminophen or Tylenol, okay? It's used for issues big and small. And this is used for all sorts of aches and pains as well as fever. All right, we have aspirin, which is known as Bayer or baby aspirin, and you see the brand Ecotrin, used in tandem with non-OTC medications for heart health, headaches, fevers, and etc. Key to note, this belongs to the family of pain medications known as NSAIDs, okay? And just a little brief thing about that, which is very important to know, NSAIDs or non-steroidal anti-inflammatory drugs are mostly used to manage pain associated with arthritis, gout, and other forms of joint pain and discomfort. It's important to mention, while it is effective, they can lead to and cause ulcers if not taken with food. Caution should always be exercised when using these drugs. With that said, here's a couple of more examples, right? Ibuprofen or Advil, okay? It's another commonly used pain medication for lots of different aches and pains, and it can also help with fever and cramps associated with period pain. Naproxen, which is Aleve, is usually prescribed for joint pain and arthritis, okay? And to go back to the idea of formulations, this applies to pain medications as well, okay? So some of the delivery systems that we have for vitamins and supplements, as well as pain medications, they're available through transdermal patches, okay, and topicals and creams. Couple of examples of that is capsaicin, okay, methyl salicylate and menthol, which is Bengay, okay, or icy hot. Camphor and menthol is icy hot. Diclofenac, Voltaren, and then menthol by itself, Mountain Ice or Biofreeze. These are considered for patients who are looking for non-systemic pain alternatives, okay? And when it comes to pain management, these can be especially useful since they can often be placed or applied at or close to the site that is causing the difficulty or pain for the patient and could be immensely helpful when it comes to their injury and pain management. Okay. So the dark side of these things is sometimes there are adverse effects, okay? So patients should be counseled about potential side effects, which are drug-drug effects and food-drug interactions that comes with using these things, all right? Calcium's a big one and can affect the absorption of antibiotics, levothyroxine and various blood pressure medications. Magnesium and aluminum supplements can cause issues with digoxin absorption, right? Aspirin in conjunction with warfarin can cause bleeding, and antihistamine allergy medications like diphenhydramine can cause drowsiness, and while they can relieve allergy symptoms, a non-drowsy alternative like cetirizine, which is Zyrtec, or fexofenadine and Allegra might be more preferable in those cases, okay? Some medications can be absorbed in breast milk and should be considered when patients are pregnant or nursing, all right? NSAIDs, is good to note, are not recommended in the last trimester of pregnancy. They could affect the fetus and its development, as well as cause complications with delivery, right? So here's some of the top takeaways that goes with this entire section. This is a general OTC and dietary supplements overview that you may see in a community setting and in a hospital setting. So good pharmacy practice would say you should it includes becoming familiar with what is available at your institution or institutions, in the dosage and strengths that are available and the routes of administration, okay? If you're unfamiliar with an OTC or dietary supplement, check with your pharmacist for drug interactions, storage conditions, compatibility or incompatibility issues, and duplicate therapy in a patient's medication history. So good luck with your studying review. Thank you.
Thank you so much, Adrian. We really appreciate that. I'm just going to reclaim host. All right, ladies and gentlemen. So our next speaker for our presentation today is the amazing Jamie Chin-Hon. Jamie happens to be the president of NYCSHP this year. Let me just get everything all situated with her. And she is going to be going over patient safety and quality assurance.
Thank you so much, Rafael. And thank you, Adrian. Can you guys pull up the slides for me, please?
Not a problem. I got it right here for you.
Thank you so much.
I-
Thank you, everyone, for joining. We're really excited to have you, and thank you for coming on a hot summer night. We know that there's so many other things you're going to be doing, but thank you for spending your time with us this evening to go over med safety and prepare for our pharmacy technician exam. Yes. I will be talking about patient safety and quality assurance, and then my partner, Lilia, will be continuing with the second part. Next slide, please.
Sure.
So three objectives I'll be reviewing are high alert and high risk medications, such as look-alike, sound-like medications. We'll go over error prevention strategies and talk about how we can stop and prevent medication errors. And then we'll talk about issues and things that we should bring up to the pharmacist to then correct orders and help to prevent patient harm. Next slide, please. So the first thing I'd like to talk about is our #1 organization that epitomizes medication safety, the Institute for Safe Medication Practices, or ISMP. ISMP is really the pioneer for medication safety. They are a nonprofit organization. They're dedicated to the education of healthcare professionals and consumers about medication safety practices. They're devoted entirely to learn, share, and ultimately prevent medication errors. And they have a monthly newsletter they actually publish and share with institutions to help share what has happened. People actually, an institution actually submit what medication errors they've seen, and they collect data to then help prevent and provide alternatives or strategies to counteract those types of medication errors. And then they also advocate to lead necessary changes for clinical practice, such as a big one, since I work in oncology, is changing the route of giving vincristine from an IV push syringe into an IV piggyback because they've seen so many errors, fatal errors, with giving vincristine, medications, chemotherapy as IV push. So they are very much advocates for change for patient safety. They also work for public policy. They want to change drug labeling to make things safer and more efficient and effective for our staff working with medications. And they ultimately want to prevent medication errors. So they're also the only national voluntary medication error reporting system that publishes newsletters, offers educational programs, they provide tools and guidelines, and they're really our pioneer organization to advocate for medication safety. Next slide, please. So high alert and high risk medications. ISMP have defined and identified high alert and high risk medications. These are medications that are likely to cause harm, significant harm, even when they're used at the right dose and in the intended way. They also are identifying medications that have caused patient suffering and ultimately medications that cause harm to our healthcare system that we really need to then spend money to reverse and fix our patients due to medication errors. So ISMP has 3 medication lists that are high alert. They consist of 19 different categories of medications. Then they have another list that specify 14 medications that they consider high alert. And then their goal is to improve and identify to manage these medications to prevent errors from ever happening again. Next slide, please. So for example, for the 19 categories of high alert medications, we have several different types of drug classes. They range from cardiac medications, medications used in the ICU for vasopressors, anticoagulants. Chemotherapy is going to be a huge one because that can cause many different harms. Inotropics are another cardiac type. Insulin, when insulin can be used incorrectly, we can cause patients to have hypoglycemia. There are also several different types of insulins, by the way they're released. We have sedative agents for patients who may need intubation. Opioids are a big problem too, because there are so many different types, but there's really different routes as well. And the different types of opioids have different potencies, so different strengths based on which opioid we choose. We also have neuromuscular blocking agents, which can cause, well, they're meant to cause paralysis, especially when patients are intubated. But if those are used incorrectly and not given with a sedative, then patients can have fatal harm. There's also antidiabetic oral agents. Something that we see in the hospital is that some hospitals restrict the use of antidiabetic oral agents, such as like a glipizide or metformin, because they can interact with medications that they receive in the hospital. So from many hospitals that I've worked at before, we actually don't use oral antidiabetics, and we only use insulin, even if the patient may not have been on insulin before. And believe it or not, IV fluids, there can be some confusion with IV fluids. They're such as hypertonic saline, meaning that the sodium content of hypertonic saline is much higher than normal saline. Normal saline is 0.9% sodium chloride, versus hypertonic saline can range from 1.5 to 3% sodium chloride. So by accidentally pulling the wrong IV fluid, we can really drastically change what we put into the patient and what the effects can be. And then different solutions. So solutions typically meaning IV, but then there's also topical solutions and other solutions, so such as TPN, that's total parenteral nutrition given IV. There's PPN, there's cardioplegic solutions, and dialysis solutions. Next slide, please. And then the high alert medication list of specific medications range with many different medications, but one thing I noticed are electrolytes. So magnesium sulfate, there's potassium chloride, potassium phosphate. These types of medications they're more like supplements, things that we normally get from dietary supplements, food, but because there's so many different formulations and strengths based on how many equivalents the patient needs replacements of, there can be a lot of confusion amongst some of these medications. Other medications include epinephrine. So epinephrine can be used for allergy, like if someone is having an anaphylactic reaction, we can give epinephrine to help kind of calm down the immune system and allow them to breathe again. But also epinephrine at different doses can be used for cardiogenic shock, like when someone is coding. Eprostenol is another one, insulin U500. That is very, very high concentration insulin, very different from normal regular insulin or insulin glargine insulin. Lantus or Humalog. This is used for patients who are refractory or don't respond well to the lower doses of insulin. So there are several different hospital policies typically outlining and restricting the use of insulin U500 for very certain populations. Another one is methotrexate oral tablets, especially for rheumatologic use. The very big difference here is that when someone has a rheumatologic disorder, such as rheumatoid arthritis, they get methotrexate as an immunosuppressant, methotrexate given orally should be given once a week. But when methotrexate is used for cancer or oncology purposes, methotrexate is typically given daily. So a common medication error is that if used for rheumatologic uses, then the prescriber might be ordering methotrexate daily because that's what the order set is showing them, but the correct order should be given once a day. So it's very important for us to review the indication and the correct dosing for medications that can be used for different purposes, different indications. Other examples are nitroprusside, opium tincture. Opium tincture is, in my experience, used to slow the GI from someone who has diarrhea, but it doesn't have any analgesic effect or pain relief effect. Oxytocin used for patients who are pregnant and going to be a stripper, that can be a medication that can be potentially used incorrectly. So that's on our specific medication list. There's promethazine and vasopressin. So these are the specific medications. So these lists are typically posted in the pharmacy. And if you ever need to find them, you can always search ISMP, high alert, or high risk medications, and they'll always pop up. Next slide, please. So how do we manage these medication errors? So although mistakes may not be very common with these medications, when something happens, like when a medication error happens, it's very severe and it can cause a lot of harm, potentially damage, and potentially be fatal. So ways we can manage these medication errors are standardizing ordering, storing, and preparing and administering medications in a logical and organized way. So, for example, storage in medications. A lot of times in pharmacy, depending on, regardless if it's inpatient or outpatient, we alphabetize medications by its generic name because it's very more convenient for us to go to the shelf or bin and find something based on its generic name for ease of organization. But a problem is that many medications may look similar because they are organized alphabetically. Another thing is preparation. We have to be really careful about when we are compounding medications. We have to really double check that we have the right medication, right dose. We calculate the right amount of fluid to withdraw, and then ultimately know exactly what we're injecting into the IV bag. Or same with oral and IV syringes. If we're going to dispense a syringe, we want to make sure it's double and triple checked. That we have the right amount, concentration-wise and also volume-wise. We also want to limit the access to high alert medications to people who may not be familiar. So especially if we have high alert medications on the unit that are in Omnicell or Pyxis, we most likely will not do that because we purposely want many eyes to have checked that medication before it gets to the nurse who's going to administer to the patient. The use of auxiliary labels are going to be really important to us too. I'm sure all of you have seen these high alert medications with a white background, red text. We stick these on a lot of bins, such as insulin. We saw like all those lists of medications to help us remember these are medications that can cause a lot of harm. So this is a way for us to safeguard and prevent errors, because we want to make sure we double check, triple check, quadruple check. And then the use of automated alerts. I know that alert fatigue when we verify orders or when you're working on computer systems can be a little bit cumbersome, but they're there for a reason. So we really need to pay attention to when things pop up while we're doing our normal daily activities. We should really read that alert and not just discard it and just say, okay, or like skip. But those have been placed for a specific reason to make sure that we are cognizant and trying to prevent error to provide the best patient care. And also requiring independent double checks. So some hospitals and institutions, they have a tech check tech program. They have one technician pulling, their second technician checking that technician's work. And then we have a pharmacist who then triple checks. And that's really the best way for us to make sure we have the most eyes and the most thought process when pulling medications. Next slide, please. So lookalike sound likes. ISMP has a list of medications that they have identified that look like and sound like. And this really does, well, they've seen that there's a lot of confusion because the words really do look similar, and a way to counteract lookalike sound likes is tall man lettering. So for example, I think in the next slides we'll see, we may have several medications in the same class or in different classes, but you may notice that some of them have capital letters in between the name of the medications, and that's really there for us to differentiate which medications are used for one purpose and used for another. And I kind of have a quick story. We have actually, I'll go next slide. So for example, heparin had been a really big issue for the past several years. One vial of heparin can be severely different from other vials of heparin. So as we see here on the left, we have heparin here as 1,000 milligram per ml. So per every milliliter, we have 1,000 units. But as we move to the right, the concentration increases. So for that 1 ml of the next heparin, we have 5,000 units. And as we keep going, 1 ml is then 10,000 units. And then the next one is also 1 ml, 10,000 units. A really sad story about this is that celebrity Dennis Quaid and Kimberly Quaid, who are celebrities, they had twins at a hospital, a very famous hospital in California. And when the nurse was administering heparin, because the heparin is given to babies when they're clotting when they're first born, the nurse by accident administered 1,000 times higher dose of heparin than they should or plan to have. And instead of giving the patient 10 units of heparin, they gave him 10,000 units of heparin. So they didn't find this out until the babies started bleeding out of the injection sites in their feet, and then started noticing bleeding from the eyes. And they really had to do a very fast root cause analysis to figure out what happened. But ultimately they found out, and they had to reverse the heparin. And this was very dangerous. Luckily, they caught them in time and the babies were saved. But this has also happened in other institutions. So it's really important to check, but also now we have to put the ownership of these medication errors on the manufacturers labeling these products, because they're so similar. Even though they're very different medications, very different concentrations, the chance of error is so high. Next slide, please. For another example, all these different types of heparins, they come in several different concentrations. There are vials, there are IV bags. This is just another example of ways they are able to now optimize changing the label based on color, based on size, the font, and it really does help to prevent confusion amongst doses of the same medication. Next slide, please. So more look-alike sound likes. For example, to the left, we have gabapentin. This helps to for people who have neuropathic pain. It can be used for seizures, sometimes restless leg syndrome. Right next to that is gemfibrozil, which is for cholesterol lowering. Very different indication. Next two are antibiotics. They look very similar and they're somewhat similar, but they really don't treat the same infection. So ampicillin is an antibiotic that has more gram-positive coverage for gram-positive bacteria, but amoxicillin is a combination of ampicillin and has another component has more gram-negative coverage. So if we accidentally switch the medications, we may not be curing that infection the same way. Then we have hydralazine for high blood pressure and heart failure on the left of that one, and hydroxyzine for itchiness and anxiety. So very easy to confuse because they can be like literally next to each other on the shelf or in a bin, but they're used for very different indications. So it's very important for us to really double check what we're giving to the patient. Next slide, please. So how can we prevent these errors? First thing is minimize clutter. So I think one thing for sure, all of us work in pharmacy, we know that how busy operations are. And when you're pulling things from the counter and counting them, putting in vials, slapping labels, it can easily get very cluttered. So I think that's really important. And also it's recommended from ISMP that we minimize clutter. Maybe we can quantify how many things we do at a time, like 5 prescriptions at a time, and put them aside so that we can put away those vials or boxes or cream ointments to be put away later somewhere else. We want to make sure that we, on the patient care units, there's a special room just dedicated to medication, so there are no extra medications laying around to be accidentally used improperly. We want to make sure that computer stations are clean and do not have medications lying around. Also, the IV room for sterile compounding is very important to keep clean and organized to prevent any accidental uses of medications that shouldn't be used. Reback method, spelling out medications. It's very easy to go to use brand names because they might be easier to pronounce, but by standard, we should be using generic names because that helps to cut down on medication errors. The use of barcode systems as much as we can, if we can. Technology is going to be there to help us. And by scanning barcodes, it really helps to help check and double check that we have the right medication for the right patient and use the right dose. And it's more efficient for our processes. Also, we want to be aware of these high alert medications. So most likely we have labels and posters hanging up on our pharmacies, but if ever you're looking for these types of medications, it's a very quick Google search. And for the pharmacy technician exam, I'm sure they're going to be highlighting many questions on these high alert medications. And then we really, really want more than one pair of eyes to look at any medication before it goes to a patient. So I know in the pharmacy, we have at least 2 people check the medications patient-wise, medication dose, frequency, everything. And then even on the floors, the nurses will then double check themselves too. And then of course, being proactive. So this is really about just culture. If you see a medication error like made, if it's from yourself or someone else, like please bring it up to someone else in leadership, because if it happened to you, it definitely has happened to other people. If you're not alone, there's no accountability to admitting that there is a problem, because it's really a systems issue and we really need to talk about and report medication errors to prevent them from happening again. And a big way is the reporting systems that we have in the hospitals. You yourself, if you see a medication error, I would bring it up to leadership, or you can report it yourself, and Lilia will go into different reporting systems. But that we really need to promote just culture and be able to talk about these medication errors, because you're not alone. No one is ever alone in a medication error. I think that's it for me. Actually, I might have another slide. But, oh yeah, some takeaways. Okay, sorry. So yeah, top takeaways from this section: become familiar with ISMP medications, high alert medications, triple check medications that look alike and sound like. We want to physically separate inventory of medications that have similar strengths and sounding medications, similar spelling of medications. And bins are going to be really helpful too. So we often put medications in bins in the IV room, outside the pharmacy, like even sometimes the nurses medication unit room. but it's really important to separate them and have auxiliary labels if they're something that can be confusing. And the use of error-prone technology such as barcode systems as much as possible. Automatic dispensing cabinets such as Omnicell and Pyxis are going to be very helpful. Computer systems, very helpful because they have barcode technology. And then, yeah, absolutely try to report all the medication errors because ultimately you want to make sure our patients are safe. Thank you, everyone.
Thank you so much, Jamie, for that. I really appreciate it. Great lecture when it comes to med safety. A lot of clinical pearls dropped throughout the entire presentation. So thank you so much for that. Our next speaker is going to be the fantastic and amazing Lilia. One moment while I give her access.
Hi, everyone.
Hi, Lilia. How are you?
Doing great. Thank you.
If anybody has not recognized who Lilia is, definitely log on to NYCSHP's IG page. She has done some amazing demonstration videos and fantastic advocacy work. And today she's going to be presenting to us the second portion of patient safety and quality assurance. We appreciate you having you today, Lilia.
Thank you.
Would you like to control your own slides?
No, it's okay.
Okay.
I don't see the slides though.
Nope. I'll pull them up right now for you.
Thank you so much. I'll just ask you two more. Yeah, I only have like 5 or 7 slides. Thank you.
No problem.
We are very short on time, so.
No worries, no worries.
But I won't take long.
Okay. 1 second. Alrighty. Of course, I'm working with a new laptop today, so this is always fun. Alrighty, share screen, presentation, share, play from current slide.
Yeah, so this is the second portion of the medication safety and quality assurance. My name is Lilia Davenport. I'm a PGY hematology oncology pharmacy resident. And so today I'll talk about the 5 patients' rights. If you could click for the next slides. Let's see. Yeah, so I'll talk about the types of prescription errors, and then I'll talk about the event reporting procedures that you most likely will be involved as a pharmacy technicians. And then finally, I'll talk about hygiene and cleaning standards to follow USP 795 procedures. Next. So this is just like a brief overview. You might get a question about the 5 patients' rights. So basically it's the right patient, the right time, the right dose, the right route, and the right drug. So I'm just going to give you an example of the right patient. So imagine a busy day in the emergency department and we have 2 patients right next to each other with the same last names. Let's say John Smith and James Smith. I totally made it up, but let's say John requires TPA for developed stroke and James came for, let's say, warfarin overdose. So both are mentally confused and 2 prescriptions are filled at the same time and by mistake attached James' key central label on a TPA bottle. We rush to the emergency department and tell the nurse it's for Mr. Smith. She grabs it, checks the name of it on a tag quickly, asks the patients to confirm the name and administers pretty much the wrong medication to the wrong patient. TPA for James Smith by mistake. James develops internal bleeding and dies the same day. So there's a lot of ways to prevent this fatal error. A lot of hospitals use even more than 2 identifiers, but 2 identifiers are a requirement. They will also have to check for the right time. It often comes up in a situation when the nurse would call you and ask, oh, can you please retime the medication? That would, require the judgment. Then also have to check for the right dose. You as a pharmacy technician would be calculating the right dose and pharmacists will be checking and calculating as well. Also have to check for the right route and of course the right drug. Next slide. So this is just a slide to give you an idea how often these mistakes happen, and we need to expect these mistakes to happen and prevent it. So medication preparation error, one example that just happened in my institution was that the pharmacy technician, they identified the manufacturer, labeled a box with a preservative-free normal saline, but once opened the box, the normal saline vials were actually missing that PF, preservative-free label on them. And for a lot of drugs, for example, for intrathecal methotrexate is crucial to mix it with the preservative-free. So it's very important to identify these mistakes and report this issue as a near miss. So because this mistake might happen in the future. So basically, yeah, this is the, as you see in the medication preparation tab, it's like 36% of the mistakes happen. Next. So how do we report it? If you work in a hospital, you probably have internal reporting system. Reporting medication errors can help identify system failures and prevent future errors. The pharmacy technicians play a huge role in catching mistakes, participating in root cause analysis. So first we would report it, and then we would investigate exactly what happened. And here, the idea is not to blame people, what have done, but the purpose of investigations just what led to a medication error. Maybe the barcoding was coded wrong when administering the drug, or Pixies had a malfunctions and so on. Then we would inform everyone about this mistake and in educational purposes, and so we'll prevent it in the future. Next slide. And be familiar with these slides. You might be asked what organization you go to report a med error. The most common one is MedWatch, but we also have medication error reporting system MERP, MedMar, or NYCSHP, which is specifically for New York State. Next slide. And event of near miss, it's any event or situation that didn't produce patient injury, but only because of a chance. Just what I mentioned earlier about the preservative-free labeling. So pharmacy technician caught that it was missing, so that would be considered a near miss. So it didn't produce any harm to the patient, didn't reach the patient, but we still have to report it. And this is just like a Swiss cheese model. Swiss cheese model is an illustrative example of how one event can harm a patient if our guards do not work appropriately, from prescribing to policies, technical issues, poor training, team culture, and so on. Next slide. And you will also have the opportunity to participate in root cause analysis, or RCA. And this is just an example. I'm not going to go over it, but basically how it happened if you look from the right to left. So on the left is how patient fell ill, but all the arrows, like what led for the patients to get the wrong medication. So the prednisone was misplaced, and pharmacists didn't pay attention, and a lot of things happened, and that resulted in the patient taking the wrong dose. The next one. This is just a screenshot of how MedWatch looks like. It's easily available for us. So we just click report problem and go step by step and check the website when we report med errors. And next one. This is just my last slide talking about non-sterile compounding. This is pretty straightforward. This is talking about non-sterile compounding. So we always make sure that we clean our workspace before and after product preparation. We would remove jackets, sweaters, jewelry. We'll wash hands with soap and water. So this is, might come up in your exam. And we will follow pharmacist cleaning and garbing procedures. Next one. And this is the summary slide. So know the 5 rights of medication administration. You would identify types of medication errors, know how to report medication error to your institution, participate in root cause analysis, and then exercise best practices of non-sterile compounding. Thank you.
Thank you so much, Lilia, for all this. I really do appreciate it. Thank you, everybody, for joining us today. Before we leave and depart, just a couple of notes. Let's first take a look at the chat if there's anything there. Please note, today's programming has been brought to you by both pharmacists and pharmacy technicians alike. Myself and Adrian being pharmacy technicians, and Lilia and Jamie both being pharmacists. So this is a joint effort, ladies and gentlemen, who are on the call today, trying to provide educational tools for pharmacy technicians to help you for the PTCE and arm you as a refresher for the PTCE. So I would ask for everybody to, for those of you that want to come for our next portion, which is going to be, let me just make sure I have my dates correctly. One moment, please.
Starting on the 29th.
Yes, for the 20, thank you, Jamie.
You're welcome.
For the 29th, it's going to be our next programming. Myself and a few other presenters will be presenting on federal law, going over laws and regulations, what to study up for, going over medications, common medications to study up on, and as far as compounding procedures and order entry will be another topic that we'll be discussing on that date. But before we leave for today, is there any questions? If you have any questions, please ask in the chat quickly.
And actually, they can unmute themselves and ask. But I just want to give the CE codes. So for NYCSHP members or people, anyone who's joining to become a NYCSHP member, the CE codes to claim these medication CE credits are for pharmacists, brand, BRAND. So it's for pharmacists. The CE code is brand, BRAND. And then the CE code for pharmacy technicians is causes, CAUSES, causes. So yes, if anyone would like to ask a question, they can unmute themselves and they can ask their questions.
There are no stupid questions, so by all means, anybody ask whatever they may like.
This is a question that came up in the chat earlier during the presentation, and that is, do we know based on the topic designator whether this CE for pharmacy technicians will count as patient safety credit?
They will count as medication safety credit, so that's the same
Okay.
as patient safety. Yes.
Right, great, thank you so much.
Thank you, Krista. Any other questions before we wrap up? Someone's trying to ask a question? Okay, well, ladies and gentlemen, with that, we're gonna end today's program. Oh, yes, there's a question?
Yes. My question is, if I'm not a member, can I still get credit for the CE?
Yes, if you sign up to be a member, you can submit for credit, and there will be several other credits coming up your way. Like this is just the start of our academic year. We're going to have tons of virtual and in-person program credits. So there's going to be like at least 60 to 70 opportunities to obtain credit, CE credits.
Okay, so
And
I
so
don't,
for
so I
pledge-
can just claim like the member now, the CE credit, right? I don't have to be a member?
I'm sorry, what was that question?
I don't have to be a member to receive the CE credit?
No, the CE credit is only for members.
Oh, it's only for members, okay. So I have to look for CE that's not for members.
Or you can join
Like,
NYCSHP to become a member. It's
Okay.
$25 to become a member,
Oh.
and you will get several credits throughout the year. I think it's well worth it. If you check the chat, I
Alright,
sent
thank
the
you so
link
much.
to
Yeah, I saw it. Okay, perfect. Thank you.
Any other questions for today? Alrighty, So, ladies and gentlemen, thank you so much for joining us for today. If anybody has any other follow-up questions, please don't hesitate to reach out through our social media. You can follow us on Facebook at NYCSHP, the New York Society of Health System the New York City Society of Health System Pharmacists, or you can follow us on IG, Instagram at NYCSHP. We thank you all for joining us today. Don't hesitate to shoot us send us a DM with any questions. We appreciate your time and best of luck for taking your exams. Please join us again next week, 7:29, same time, same place. Have a great evening, everybody, and have good luck studying.